So atrial fibrillation and flutter. And let me just start by saying that with regards to flutter, most of what we cover for AFib will kind of apply to a certain degree to AFib. The main thing is that flutter is a little bit more organized than atrial fibrillation, like a lot more organized than usually one or two areas that create the extra signal in the atria. So let's see here. Okay, so atrial fibrillation. This is me on the dance floor, out of sync electric slide, versus maybe a little bit more normal sinus rhythm here, right? So I think the main lesson from atrial fibrillation is kind of understanding that the heart requires synchrony in order to move blood flow through it and to the rest of the body. So atrial fibrillation is disruptive and it reduces efficiency, but unlike ventricular fibrillation, often it's not just deadly by itself unless happens to be really high rate episode in the context of other things going on. And we'll talk about the hemodynamically versus normal or hemodynamically unstable versus stable patient. So let's start with a case, because I think this is a great way to bring us through atrial fibrillation, and this patient probably not unknown or that you maybe even just saw in the recent past. So Cheryl's a 66-year-old woman. She's well established. She presents with three-month history of being tired a lot more. She's had moments where my heart beats fast. And this causes her to feel dizzy and lightheaded. She is on losartan hydrochlorothiazide 2012.5 and amlodipine 5. She says, I've had high blood pressure for years, which you knew because she's established, but no fever, chills, or sweats. And she doesn't report any abnormal bleeding. You know, these are kind of the differentials. You start to kind of, oh, what's going on in the 66-year-old? Why is she having palpitations? You know, she's tired more. Past history is hypertension, again, for years, menopause at age 55, and then the meds as per above. Not really much to shake a stick at here in terms of vitals, but you notice on physical exam, she has this irregular rhythm. And I think that's probably the most pathognomonic taught physical exam for atrial fibrillation, is that it's irregularly irregular. Again, not really much here to shake a stick at in terms of labs, but this is probably the most common set of labs. Well, not lipids perhaps, but A1C, TSH, you'd get a rest of a cardiometabolic panel, CBC, and a CMP, and we'll talk about that. But I'm not going to provide it for you on this one. So what is atrial fibrillation? Again, I think this is nice. It's a gift that was made from the CardioSmart app. I think I've talked to you about that before. It's free, it's available, it's nice. It's on Android and Apple as well, but a nice way to teach patients between normal, AFib, coronary disease, all of that. But it's a common heart rhythm disorder. In fact, it's the most common heart rhythm disorder that you'll find out and about in the wild. So here's the gold standard, right, in EKG, and this is single lead. Again, it's relatively cheap, it's efficient, ubiquitous. You have it on your wrist, probably. If you have an Apple Watch or a Fitbit or a Garmin that has capability of single lead EKG capture. And we're not talking about PPG, which is that photoplethysmography that gets heart rate, but here actually getting an EKG. And this will provide the diagnosis of AF. Here you'd be like, really, is this AF? Can it be? Well, you don't see any discernible P wave that's associated necessarily with the QRS. You'd say, is that one? Or is this like some, really bad EKG single lead? Not sure. Are those truly P waves or are they nothing? What is all this stuff here? But you can see it's irregularly irregular. The R to R intervals do not line up. If you were to take a caliper and try to line these up, they wouldn't. And there's not really any discernible P waves. That's really the gold standard for AFib. It's R to R intervals, these big QRS or R to R intervals that are just irregularly spaced, and it's irregularly irregular. And then no discernible P waves really to speak of. So then the problem here is that we don't really know what the burden is. Just calling it AFib is like saying blood pressure or hypertension. We kind of know it's a diagnosis, but hypertension of like 220 over 110 is a little bit different than 135 over, 85, right? So we don't know how often it's occurring, for how long is this, kind of coming and going. So it's kind of like saying an ice cream cone. Hey, I'm gonna buy you an ice cream cone, and Leslie on the call gets this big cone, and for me, I'm like, hey, here's my ice cream cone. So just calling it AFib doesn't really give us a sense of the size and burden. So, sorry, I actually can't remember why I put that GIF in. So basic clinical evaluation. And this is, any one of us can do this. And a lot of my now graduated PA students always ask me, hey, I have a patient with AF, what should I do? And so these are the basics here. It's nice to line it up. If you can, order transthoracic echo. If you don't, cardiology will. CVC, BMP, TSH with reflex T4. And I would add an A1C, but that's really part of kind of a cardiometabolic assessment. And that's in here, as you're thinking about what are class 1 things to assess for. Because what you're trying to understand is what's driving this? What's driving the atrial fibrillation? And then what I wouldn't do is, in the past, I've been at this kind of 20 years. In the first 2 years of cardiology, when we saw AFib, we would often order stress tests straight up. And I know it sounds weird now, but at the time, we were commonly thinking of ischemia as the reason or the etiology for the atrial fibrillation. But I wouldn't do any testing straight up for any of these unless there are other signs and symptoms, such as chest pain or discomfort, that might lend you to evaluate for those things. So here, again, is kind of the gold standard look of what an EKG is when you have atrial fibrillation. You'd say, well, some of those kind of line up, and then suddenly it becomes irregular here, and then it's irregular again. Here's the best way to look at it, because it's a rhythm strip of lead 2. You can see those really aren't smooth. It's not sinus rhythm that's going on here. And then the other thing that I mentioned was P waves. So there are discernible P waves here, but they're not necessarily associated to each of the QRS complexes. They're just kind of all over the place. And then you got these additional P waves that just pop up occasionally here and there and everywhere. So that's important to realize. This is kind of the way that we think of AFib is that it's irregularly irregular, and then no discernible P waves with a QRS complex. In fact, lead 3 is a really good one to think about, is this a flutter? Because you're seeing kind of these 2 and 3 to 1 type of P waves that seem to be sawtooth in nature. So here's the pillars for atrial fibrillation management. This comes out of the recent AFib guidelines, and it was nice to have these guidelines just recently published. And I would say that this graphic here is really where it all sits. And we'll talk about this in terms of the stroke risk. We always think of that with AFib, and then we think of the symptom side of things, like rate, rhythm, all of that. But really the central pillar of all of this is to optimize all modifiable risk factors, because it not only reduces risk of first-time AFib, but it reduces the risk of recurrent AFib. So if you're just treating with a medication to reduce stroke, and if you decide rate or rhythm control, you're really not optimizing any of the care, because that comes down to how do I reduce recurrence, and how do I make sure that the patient reduces their stroke risk outside of giving an anticoagulant. So these honestly are really the central, the foundation, as it's shown here. So you can see head to toes, right? That's the kind of acronym that they've given us here. So, you'd ask, what's the risk of stroke? How do we reduce recurrence with risk factor modifications? And then should we decide rate or rhythm control? And I think that really, if you're not thinking of the entire piece here, you're going to leave your patient really without true care, or at least optimal care. Okay, so as we go into this is a nice figure, because I think most of us, for the longest time when we thought of AFib, we kind of thought of these four terms: a paroxysmal AF, persistent, long-standing, and permanent. But really what's nice about the staging here is that it goes pre-atrial fibrillation, which is essentially, those that are at risk, then those that have the structures that pathologic structural differences like atrial enlargement, or they have some ectopy, short bursts of atrial tachycardia, and a flutter is considered a pre-atrial fibrillation risk. So, if you're not assessing all of your patients for being possible risk for AF, we're probably doing a disservice to the patient, because again, it's about 25% of the population greater than 40 years of age that will have AFib. So it's common, folks. But then as we think of the traditional terms here of paroxysmal, persistent, longstanding, and then permanent, this helps drive different therapies. What are we going to do with these individuals? And again, everyone, you treat the modifiable risk factors. You modify them, you optimize them. And then it's in this space here, once they're in stage 3, 4, that we're thinking of what are the pathophysiologic changes, the stroke risk, treat those symptoms. Okay, so rate versus rhythm. Let's talk about that. And what does that mean? So again, rhythm in this case is the opposite is normal sinus rhythm. And then, of course, you have variants of rhythm that aren't necessarily sinus rhythm per se, but they're not atrial fibrillation or flutter. So in the permanent AF state, that just basically folks have tried rhythm control, maybe ablation, medications, etc., and you're just going to leave them in permanent atrial fibrillation. Again, unlike ventricular fibrillation, which is deadly, AF itself, there are plenty of folks that remain in AF atrial fibrillation, and we control for its speed at the rate that it runs, and then, of course, stroke prevention. Okay, so in our case, Cheryl's a 66-year-old woman. We've talked about it, but what AF stage is Cheryl in? Is she stage 1 at risk for AF? Is she stage 2? She's pre-atrial fibrillation. She's stage 3 in atrial fibrillation, or is she stage 4, permanent atrial fibrillation? And I think here we can rule out 1 and 2 because, well, she was at risk. She could have been pre-AF. I don't know. We don't have an echo, but in fact, she is in AFib here. So she's at least stage 3, and the determination of permanent really depends on how she responds to therapies going forward that are targeted towards staying in sinus rhythm. Okay, so AFib, here are the different causes and risk factors. I think it's important, I won't belabor this, but it's more prevalent in men, but only just a little as we advance in age. So again, 40 and above, we have about 25% of the population. But truly, as each decade progresses, the percent of those individuals increases as to who has AFib. Those with hypertensive heart disease, because it's changing the structure of the heart. And when you do that, you put different stressors on those cardiomyocytes, leading to disruption in rhythm control. And coronary artery disease also is a risk factor. And that's what I just presented this morning with my abstract, is that really atrial fibrillation is associated. I mean, we knew this, and we just confirmed it with our data set that AFib is associated with coronary disease and not with another marker that I talked about, LP(a). So rheumatic heart disease also is a strong risk factor. And then these other conditions. And you'll notice that each of these conditions, as they're associated with AFib, have to deal with structural abnormalities with the cardiomyocytes. And that's really what's happening, is you're kind of, it's like, the electrical lines in the house. If you start pulling on them or tugging on them, and it starts to short out. And that's kind of the driver of having atrial fibrillation. Here are other risk factors. So you've probably heard of holiday heart, where folks, have a sudden withdrawal from acute alcohol. Of course, anything that inflames the heart. So again, structural chest trauma, or thoracic surgery. Here, thyrotoxicosis. So that's why we get a TSH. Obstructive sleep apnea puts pressure on that heart when you're not breathing. And so again, it starts to enlarge and hypertrophy, or dilate. So all these other things here with regards to atrial fibrillation. So I speak of the etiology in terms of how it impacts the heart to lead to AFib, because no one remembers a whole list of things like this. It's better to remember the principle of how those diseases lead to AFib. Oops. Okay. Oops. Let's see. Yeah. So that last point here is that there's kind of a less common is just having what's called lone AF. Usually, if you dig, there's something else that has led to atrial fibrillation in people. But when I first came to cardiology in 2012, we were looking at genetic components. So there were a subset of patients that had lone AF, so-called lone AF, but it was genetically mitigated. The mutation was the reason for the AFib. So then as we look at different risk factors and what is most impactful on AFib and its incidence or the cause of it, you can kind of see from hypertension down to diabetes how they impact atrial fibrillation. And so again, this comes back to the pathophysiology, the stretch cardiomyocyte of those tissues. And so they're electrical, and as you stretch them, or if you're an idiot and run into an electrical fence, that can be problematic, right? And again, pulmonary veins. So I think the importance here, and I'll go ahead and stop here for a second, because the pulmonary veins are not cardiac tissue. It's not heart tissue. They are veins. So, and the best way to explain this is you don't have cardiomyocytes in your legs, but you have veins. You don't have cardiomyocytes in your toes, but you have arteries. So those are different tissues. Yes, they deal with vascular, but cardiomyocytes are highly specific to the heart, and each of those cells can have its own electrical beat and signal. And so the pulmonary veins, as they come back into the backside of the left atrium and attach there, where they connect, if you've seen two different materials kind of connect at their juncture, then those pulmonary veins, if they stretch, they start to stretch the cardiomyocytes around them. And that's why it's a target for a ablation. Atrial fibrillation ablation is around the pulmonary veins, is because you're trying to isolate that stretch from affecting the cardiomyocytes. You scar that down. So anyways, that hopefully that helps to understand that a little bit. Regardless of the underlying risk factors, really, again, it's anatomic electrophysiologic changes in that myocardium, the cardiomyocytes. Okay, so atrial enlargement, atrial pressure, or inflammation of those atrial tissues. Again, if you just kind of understand that pathophysiology, you recognize that it's the cardiomyocytes that are under attack from some reason or another, whether it's stretch or inflammation or infiltration. So not unlike we see with amyloidosis when it starts to infiltrate the cardiomyocytes. Okay, so here the problem then is when you have atrial fibrillation, and here as you're looking at the heart, it's rotated slightly. It's rotated so that really what we're seeing is mostly the right ventricle here, some of the left ventricle, and that right atrium kind of comes to the fore. But the left atrium kind of gets rotated behind the heart a little bit. What we're really seeing is the appendage here of the left atrium. So that's this real weird squiggly thing, and we'll have a better picture of it later. But that's where the clots are most likely to form. Is here. The rest of the left atrium can function, it squeezes, etc. But this vestigial organ of the left atrial appendage really has no good squeeze or contractility. So when blood is pooling in here because of poor contraction, then it pools even worse in the left atrial appendage, which leads to clot formation there. And then of course, if those get sent upwards to the brain or somewhere else, then they're thromboembolic, and what follows is, of course, infarct. So here, just coming back to the terminology of stage 3, paroxysmal AF, this is really, terminates spontaneously or with some intervention within 7 days. So if you happen to cardiovert the person, before 7 days, but it can recur. So paroxysmals kind of come and go. And it's not like you cured it or fixed it, but it's this atrial fibrillation that's also not permanent and chronic, ongoing. It just kind of comes and goes. And we see this on pacemakers, with something that's monitoring someone 24 hours, 7 days a week, etc. So we'll see a lot of paroxysmal AF in patients who have atrial fibrillation. Persistent is basically kind of like paroxysmal, but it's just not terminating on its own within those 7 days. It really requires pharmacologic or electrical cardioversion to get to normal sinus. And that's really the difference between these two. Is they can come and go, but the persistent doesn't spontaneously terminate. You have to do something for them. Long-standing persistent AF is basically AF that either you didn't capture, they didn't capture, or someone's kind of, the patient comes in 6 months into it, like, oh, I've been short of breath, like Miss Shelley, who's been 3 months of this, probably has long-standing persistent AF to a degree. It's only 3 months. If you let it go more than 12, then she would meet this criteria here. As of now, it sounds like she's persistent AF. And then there's the permanent AF folks. These are the individuals with persistent atrial fibrillation who really, between you and the patient, you're just not going to try to go to rhythm strategy anymore. You're no longer trying to get normal sinus. You've stopped, antiarrhythmics because maybe they have side effects. Maybe they've had 4, hopefully not, AFib ablations, and it still hasn't worked. And so you're opting to let them stay in AFib. Okay. But I think that the important thing is so many patients, if you're doing a physical exam and you're checking pulses each time, they will not often show or present like Shelley is. We see it all the time in primary care where it's a new diagnosis of AFib without any symptoms. The patient's like, oh, I didn't know I had AFib, but it was an annual wellness exam and someone did an EKG and they happened to be an AFib. And so it's about less than 50% actually that have symptoms with AFib. So we compensate very well, actually. But the other part of it is a lot of folks are sedentary, and so they don't really notice that their heart is in AFib, that it's inefficient, because they're just kind of sitting around anyways. But boy, if you need that engine to have good synchrony going up the stairs or running or walking fast, suddenly you'll feel it putter, because it's just not getting blood flow in the right direction. But these are the symptoms that can be present if someone has AFib and they are symptomatic. Then, yeah, of course. I mean, this all makes sense, because if you really have an inefficient heart pump, you're not, it's either going fast by itself, so palpitations, tachycardia. But if you're not efficiently moving blood, hypotension, I mean, your blood pressure will kind of, drop down. You get fatigued because you're not moving blood forward. Dizziness, lightheadedness, all that makes sense. Dyspnea as well. And then angina, I mean, as a function of decreased blood flow to the heart. The heart gets supplied by, by its own heartbeat. And so if AFib is around and you have even, a modest obstruction already, like 50% narrowing, and then you decrease the efficiency of blood flow, you can experience angina. And of course, pre-syncope and syncope, but those are infrequent. At least syncope is infrequent. So here, when we talk about what's this AFib with rapid ventricular response, and does everyone have that when they have AFib? No, and it's not, something that's with AFib that automatically you give them a diagnosis of rapid ventricular response. Here, it's when heart rate is greater than 100. So unfortunate or fortunate, this is a very healthy atrial ventricular node. It is healthy enough that it's just sending signals down. So remember, normally it's sinus to atrioventricular. So that's how normal sinus is, the sinus node down to the AV node. But if this is all just all over the place, and then AV node is only sometimes transmitting that information, then that's where that AFib comes in. But if you've got a really healthy atrioventricular node, it's going to send those signals more often. And that's when heart rate can get above 100. Fun fact, AFib itself can be at rates in the atrium of 500 to 600 beats per minute in just the atrium. Now, if your AV node was very healthy and conducting all of those down, you'd die. It'd be VFib. And so what really happens is the AV node, as healthy as it is, often doesn't transmit more than maybe up to 180, 190 beats of the AFib. So fortunate for us. But that's RVR, right? Rapid ventricular response. And so if it's way too rapid, then you can get hypotension. You can have a heart attack or tachy-induced myocardial dysfunction. So heart failure, because the heart's like, oh my gosh, I've been running at 150, 160 beats like forever. I mean, I feel like crap after a half marathon. Imagine, going beyond the 2 to 3 hours, and you're like now 48, 72 hours of a heart rate that's in the 130s to 160s. So that heart can start to become cardiomyopathic and start to you have heart failure. If you did an echo, their EF would drop or be shown to drop. So here, this can go back and forth depending on that AV node, or if you happen to have any other therapeutic medications on board where you're blocking that AV node. So think of how diltiazem, a calcium channel blocker, and a beta blocker like metoprolol work. They block down the atrial ventricular node. So it slows the signal that AV node can respond to, and therefore heart rate will drop because you're taking this very healthy AV node and you're slowing that response rate down. That's how these AV node blockers work. And alternatively, if you don't have these therapies on, that's why you can get rapid ventricular response. Okay, so here, RVR, AFib, ventricular rate up to 180, commonly around 120, all the things I said, then echocardiogram. And the reason why you want to do echo, there's two different kind of things you're assessing for. Although a regular transthoracic, TTE, is more commonly ordered, you don't often get a chance to see the left atrial appendage on that. So you can't tell if there's clot or anything, but you can certainly see if blood is slow, and you'll get the smoke looking blood flow, and that's always a little scary. But on TEE, transesophageal echo, man, sometimes you can see that clot like flipping around, and you're like, holy crap, hang on, man, we'll get you some anticoagulation. Don't give up, just stay there. But yeah, if it then embolizes, all sorts of problems, right? So then from my perspective, we can put monitors on Holter if it's happening every single day. They're having symptoms, but if they're having it once or twice a week, maybe once or twice a month, then you get an ATM monitor, an ambulatory telemetry monitor that lasts a month. Most of the Holter monitors are 1 to 3 days. We are getting the Zio patch, I hear, which is a 14-day, just slap it on, little sticker, instead of like multiple leads and a stupid little Holter monitor thing that they have to keep on. So I'm hopeful we'll see that in the very, very near future. In fact, here I just saw one of the Zio reps, and they tell me that they are in conversation with Intermountain. So we're excited about that. So here again, laboratory testing. Just don't want to belabor this, but I'll send the slides so you can see. Here, just so you can see the different echo views, the 4-chamber of the heart view here. I wanted to make sure you could orient yourself with this diagram as what that looks like. And then this is, what we hope to see is really, this is normal sinus, actually. It's not AFib. You can see how regular that is closing and opening. But this person here has this huge, large goober going on. And geez, if that's not, this huge clot in the left atrium that's extending down to the left ventricle, that's super scary. Okay, so, management can be complicated and multifactorial. It's really tailored to, shared decision-making, right? But it comes down to two things, really. We're trying to control symptoms. So if symptoms are coming from rate, then you can slow the heart down, or maybe let's just put them back in rhythm. And then the second part is stroke prevention. So here's just kind of a little graphic view of that left atrial appendage, clot forming, and then oh no, and maybe that's what happened to me. But increased risk of stroke. Okay. So anticoagulants, let's start there because I think the rate rhythm stuff can get a little complicated, but anticoagulants, it's important to understand when to consider because you're managing them, we're managing them. GFR is a big deal when you're looking at dosing. Sure, creatinine, clearance, creatinine, all that good stuff, but GFR is a great place to start when you're considering the dose for anticoagulants. But here, really, you need to calculate their annual stroke risk. Not everyone with atrial fibrillation requires anticoagulation. And I know that sounds funny, but when you look at scores like CHADS2, Atria, CHADS2 VAS, these are all in the guidelines, and you can use any one of them. But if you calculate a stroke risk, an annualized stroke risk of greater than or equal to 2%, that's a class 1 indication for anticoagulation. And you're probably thinking, well, what about the other 98% of people who have AFib, same risk, and may not have a stroke that year? You'd say, yeah, that's right. There's still a group of people that won't have stroke, but you can't tell which one it is. You just know that all of these folks are at risk, and therefore it's a class 1 indication and recommendation for anticoagulation. So again, this is paroxysmal folks, persistent folks, long-standing, and permanent AF. If you've calculated that stroke risk and it's greater than or equal to 2%, then yeah, anticoagulation. What if it sits less than 2%? Well, if it's greater than or equal to 1 and 2, consider anticoagulation. And then here, I think is the most key piece of this. Now that we're kind of heading into an era where they've all been out long enough, we're going to start to see generics. DOACs, time and again, have beaten warfarin, vitamin K agonist. And that's what this piece here is. So when and where possible, DOACs. You don't have to mess with thiamine therapy, INRs, all of that. However, the only people that you then think about warfarin and not DOACs at all is when they have moderate severe rheumatic related mitral stenosis or a mechanical heart valve. We have not been able to show that DOACs help with mechanical heart valves. You're still going to have clot and thrombus in those individuals. Okay, so then when we think of this, candidates for anticoagulation, what about antiplatelets? So, again, I've told you, coronary disease is highly associated with AFib. Our paper shows this again, or our abstract today presented. So a lot of these patients don't have AFib by themselves. They typically have coronary disease, peripheral arterial disease, stroke. So they're already usually on an aspirin or P2Y12. Why can't I just use that? They are not alternatives to DOACs. Just please don't. If you're doing a shared decision-making process where the patient says, I can't afford the DOAC, stupid US healthcare system, or they just don't want to be on it, do not pretend and do not let them think that the aspirin or Plavix or Brilinta or whatever is reducing stroke risk. It's just not. Just say, okay, then you're just not on any stroke prophylaxis. And they're like, well, what about my aspirin? I said, that's for your heart. Well, what about clopidogrel? That's for your heart or your brain or your peripheral arterial disease. But when I say brain, I don't mean stroke. So please do not use monotherapy and antiplatelets and think that that's stroke reduction. It's not. Okay. Okay. So as we kind of go through this, again, when to consider anticoagulants, this right here is helpful when you're thinking of stroke and systemic embolism. So, VTE, prophylaxis, venous thromboembolism, then again, greater than or equal to 2% per year, class 1 indication. And then you can think about anticoagulation when they score at 1 to 2%. So that's a 2A. But the anticoagulation of choice, again, DOACs. DOACs over warfarin. Notice the red, aspirin either alone or with clopidogrel, even dual antiplatelet. No, it does not reduce stroke risk. Stop it. And then no risk factors for stroke, aspirin to prevent thromboembolic events. So let's just say they're less than 1% in terms of stroke risk. You could use an aspirin, but it's still no benefit, right? But please don't use them and think that it's reducing stroke risk. This is from the AFib guidelines. I just wanted to show you warfarin. and then dabigatran VKA, which is warfarin, direct thrombin inhibitor, dabigatran, and then the factor 10A. And I think it's nice that rivaroxaban has an XA because it's a 10A inhibitor, pixaban, XA because it's a 10A inhibitor, edoxaban, 10A inhibitor. You'll notice that dabigatran does not have an XA because it's a direct thrombin inhibitor. And then here kind of gives you the half-life, renal dosing, all of that. All important, but I'm not going to discuss that at this point. Oops, sorry, I got ahead of myself. Okay, this is so helpful because what if you started a DOAC? When should you do lab monitoring? And what should you be monitoring? It looks complicated, but it falls under these three headings. You want to look for hemoglobin hematocrit because they're on an anticoagulant. You want to look at renal function because that's how most of these are metabolized. And then you want to look at liver function because, again, liver hepatic dysfunction is where, we think of platelets and fibrin and all the fibrinogen, etc. So when that's not working well and you add an anticoagulant, bleed everywhere. So let's start with hemoglobin hematocrit. The minimum interval for CBC should really be every 3 months. But if they have minimum interval is 6 months when they have a low bleed risk. But if they have a high bleed risk, then it should be every 3 months. So half every 6 months. But boy, if they show that they have a high bleed risk, then every 3 months. And then on this side, when you're thinking of a BMP, how often should you do it? Well, if the creatinine clearance is greater than 60, yeah, every 6 months. If it's every 3 months, if the creatinine clearance is dropped 30 to 59, they've got CKD stage 3, then every 3 months. And then, boy, if they're in the dumps here in terms of the renal function, then much more often should be checking their labs. And then in terms of liver, again, this is starts from over here and then over to 1 to 2 months. So if there's no liver disease, then sure, every 12 months in terms of a CMP. But if they have any type of liver disease, then you start to reduce the frequency or the intervals between testing. So hopefully that's helpful in terms of DOAC lab monitoring. Let's come back to Cheryl. So what is her risk for stroke? We know that she's 66. She's already had hypertension. Now she has AFib, but we have to calculate before considering anticoagulation. So let's look at this. This is the CHA2DS2, 2. And then what you see is that she is 65 to 74, so she gets 1 point. She is female, so she gets a point there. No heart failure history, but she has hypertension. So she gets 3 points total. And that's when you look down here and see that it's 3.2% per year. So greater than 2. It's greater than 2%. And then looking over here in terms of her overall risk of stroke or thromboembolism, this is kind of rate of ischemic stroke versus the risk of stroke, TIA, and systemic embolism. So you can see that it's not a small percent, but it's enough that by guideline and not really arbitrary. I mean, we do recognize just how devastating stroke is. And so a CHA2DS2-VASc 3 for women or higher will net a recommendation for anticoagulation. In men, it's 2 or greater. But you can see both of them are 2% or higher per year. Okay. So here's the HAS-BLED scoring. So on the one hand, you don't want a stroke, but on the other hand, you don't want to cause increased bleeding. And so I did not factor this in for her, but you can see what the acronym is and what you're looking for in terms of understanding what the score is, and then interpreting whether it's low risk, moderate, or high risk. And then, is it an excuse for stopping anticoagulation or not using anticoagulation? No, but it should be factored into monitoring of the patient, and they're letting family and friends know. So here is a kind of a better list in terms of the different DOACs, the direct oral anticoagulants, their dosing, and then what the adjustments are based on creatinine clearance. And what you'll find is that apixaban really, for me anyways, I use apixaban most often. They don't really have a dose adjustment for creatinine clearance unless it's serum creatinine greater than or equal to 1.5. But it's really 2 of the 3 risk factors that reduce the dose from its usual 5 down to 2.5, whereas others have an earlier reduction based on creatinine clearance. Again, yeah. Oh, is someone responding? Sorry. Okay, so coming back to the case, she is stage 3, as we discussed, atrial fibrillation. We're not sure yet whether she's paroxysmal, persistent, or long-standing persistent, but she does meet guideline criteria for stroke prophylaxis for an anticoagulant. And you'll probably hear that my own bias is towards apixaban. I know it's a twice-a-day drug. I'm usually against a twice-a-day drug, but the clinical trials are fairly clear that at least head-to-head or in those trials, apixaban seems to win out, and it also has great cardiovascular risk reduction as well. Okay, so some caveats for anticoagulation. AFib needs patient context. Remember the ice cream cone. You can't just say, oh, I'm going to give you an ice cream cone, and it's this small little dinky kitty cone for Viet and the big, large, several scoops for Leslie. What is it? What is AFib? And so you have to understand like what the context here is. Artesia was a nice study that looked at atrial high rate episodes. So these were actually captured by pacemaker, and it was at least greater than 6 minutes, but less than 24 minutes. So it's a short time frame, but all of them were at least a CHA2DS2-VASc of 3 or higher, including the men. And you excluded anyone by EKG, telemetry, or Holter that was greater than 6 minutes, regardless of symptoms. So what was the outcome? Well, apixaban was used against aspirin. Yes, I know I just told you don't use aspirin, but this was the randomization scheme for this trial, and it was reported out in 2024, which kind of leads to some of the guideline here. And they weren't following the current guidelines, but this was before we really had a more solid evidence for it. The idea that we just cannot use aspirin for stroke prevention. And here you reduce the stroke risk by almost 37%, statistically significant, but you do incur an increased bleed risk by 80%, and that is statistically significant. So, I think while you can feel comfortable, you reduce some stroke or systemic embolism in these individuals, I don't know that the bleeding risk outweighs that potential benefit. It's something that you should have a shared decision-making process with your patient. So AFib, I talked about the anticoagulation. What about devices to reduce stroke in atrial fibrillation? Well, that left atrial appendage, like I said, it has so many weird looks to it. The chicken wing, the wind, no joke. I was in one of the conference talks several years ago, and these are actual terms. And this is from a paper that was recent, 2023. And this is what they see when they go in there. So how do you really, occlude these appendages when they have such funny looking physiology or anatomy rather? Well, this is kind of the different ways that we do it. Not everyone can get a Watchman device because if it's, cactus or chicken wing or whatever, this is probably not going to fit inside there very well. Here's a lariat device where you go extracardiac, but also intracardiac, and you keep a stiff catheter there so that when you loop the lariat device over and you trap it and stricture it, it's kind of like banding hemorrhoids, I guess, is really the way to think about that. And then it atrophies here. But you can see different ways with cryoablation. This is left atrial appendage management, so we won't necessarily talk about this, but they'll do this first to isolate the atrial appendage, and then the lariat device is used afterwards, or they can use the AtriClip, again, extracardiac, but they slip that over, and then they just squish that down and clip that off, and or an open surgical excision and ligation. So it can be done by mini thoracotomy or during a bypass where the heart's already exposed with sternotomy. And then a lot of our surgeons will do a left atrial appendage excision in patients that have a history of AFib prior to the bypass. Not so much routine in people who are getting a bypass, but no history of AFib. Okay, so rate versus rhythm. There's no clear choice, but some variables that may help us decide. So this, these are two people fighting over rate versus rhythm, and like, who's gonna win? I don't know. Hopefully you remember Napoleon Dynamite here. And so the major trials that we kind of think about are the AFFIRM and the RACE trial. These are now pretty old, 22 years now since these trials. And I would say we have an enormous, like light years ahead in terms of anticoagulation, which really affects the thought process here. But also the treatments are different. When you're doing rhythm control, you're not just thinking about antiarrhythmics, you're thinking about ablation, and that's gotten so much better. So the AFFIRM and RACE trial, great, they're historical, and I don't think that they're very helpful in the current era of management of AFib. But this, so this is me. I'm actually the rhythm control guy, making a quick slap on the face and running off. Okay. So as we think of the AFFIRM trial, so I'm going to come back to this. This is usually what you'll see is like, oh, it doesn't matter. Rhythm and rate control, they're kind of the same. And in fact, they'll point out that rate control looks a little bit better, but it wasn't statistically significant. And so a lot of our primary care providers grew up on AFFIRM, and they're like, yeah, we'll just keep them in AFib and rate control them. But let me just point out to you that here, what you have, this solid line here is rate control and the rhythm control group. This is rate control drugs and rhythm control drugs. So as you kind of make a line across, the rhythm control group, before they started on randomization, they were already, a lot of them, up to 30, depending on which drug here, it could have been like up to 60% of them or more that were already on a rate control therapy. But at any time through the 5 years that they were followed, it was even higher using rate control with rhythm. And that's in fact what we do nowadays. We do rhythm control, but often we have a PRN as needed beta blocker that's on hand. You don't use it daily or chronically. And some of my patients don't even have a rate control prescription for metoprolol or whatever. And then as you look at rhythm control, the therapies here, amiodarone down to dofetilide, this is the rate control group. And this was, there weren't a lot of them that were on initial drug therapy at the time of randomization. But as we move forward in time, this is at any time through the study, like upwards of 10 to 20% of the rate control. If you were just using metoprolol or diltiazem or whatever, through the 5 years, up to 1 in 5 individuals were placed on a rhythm control group. So, you have to do an intent to treat and per protocol analysis. And I would say that this Kaplan-Meier curve is just not right. I would say that in general, it didn't favor rate control at all, because up to 1 in 5 of those individuals were on a rhythm control drug. So here's the East AFNet 4 trial. I'll point out that it was early rhythm control. And they, it was either antiarrhythmic or ablation up front, or they would just kind of like, oh, usual care, let's just follow the AFFIRM trial. They're on a metoprolol or diltiazem or whatever. They followed these people for 5 years. And you'll notice over here that statistically significant, there was a reduction in cardiovascular death and stroke between the two groups. If you did an early rhythm control strategy, you tried to keep them in their native normal sinus rhythm. Okay, so statistically significant and upfront care. So here are the variables that would favor either rate control or rhythm control, and really it falls down to patient choice. If they want to be in AFib and you just control the rate, fine. And then age, if they're older, they probably won't respond well to antiarrhythmics. If they have had a longer history of atrial fibrillation, they probably won't do well with rhythm control because those cardiomyocytes have learned to be in AFib. But also, if they have fewer symptoms, you might not want to tip the boat and add an antiarrhythmic that could potentially cause symptoms. Okay. And then the the anatomical features here would either favor rate control or rhythm. You can see if they already have an easily controlled heart rate, maybe you don't have to use an antiarrhythmic. But the larger the size of the left atrium means that it's not going to respond very well to rhythm control measures of ablation and medications. If they have less LV dysfunction, probably you're okay leaving them in AF. But today, we have multiple abstracts we're presenting from Intermountain to the heart rhythm group, where more LV dysfunction, the worse it is for those patients to stay in AFib. So it favors trying to ablate them early or get them on antiarrhythmics. Okay, so management, here's acute. This will now really, the question is, boy, if they come in and this first time I've seen AFib, or maybe they have some symptoms, but are they stable? If they're not, we just cardiovert them. If they are stable, but maybe they have decompensated heart failure. If yes, then, what do we have? Well, we have IV amiodarone, but please don't use calcium channel blockers. That will cause harm. And in fact, we don't use verapamil or diltiazem in folks that have heart failure and AF, but rather we tend to go with beta blockers. Again, this is in folks that do not have decompensated heart failure or any heart failure. So again, hemodynamically unstable. Typically, we hospitalize immediate treatment of AFib, including cardioversion, and then the general cause is rapid ventricular rate, which is created a situation in terms of perfusion for their heart and or acute heart failure from cardiomyopathy. So we'll use IV beta blockers, but don't use calcium channel blockers in heart failure, and then urgent electrocardioversion for those that are in shock or severe hypotension. The stable patient, though, you can manage outpatient. You don't necessarily have to do an admission for them. I see them all the time. I've diagnosed and identified AFib for the first time. We just, we then start the process and anticoagulate as we kind of consider options for rhythm management. Notice I didn't say rate management, but rhythm management. But if they need to, I'll initially have rate control up front until we can cardiovert and then decide what to do for rhythm management, including AFib ablation. But here's an interesting kind of thought that up to 66% of those with acute AFib will revert back to normal sinus without cardioversion. So these are the paroxysmal AF, where it spontaneously terminates. And chronic rate control. So if you decide that you're just going to, keep them in atrial fibrillation, what to do. And for those that are in heart failure or have HFrEF, then again, don't use calcium channel blockers. It's beta blockers, class 1, and then you can use digoxin. If they have HFpEF or just normal heart LV function, then you can use beta blockers and digoxin. And then, of course, makes no sense in permanent AF to use dronedarone because it's an antiarrhythmic. If you're going to keep them in AFib, then just keep them in AFib. Okay, so A-flutter, just whatever. It's the same as management in terms of AFib for the most part, but it's much more organized and typically is, we say one to one is pretty quick. It's like 200 plus beats per minute, and then 2 to 1 is about 150. So this is just how much the AV node is conducting through. And then 3 to 1 is usually about 75 beats per minute. And then 4 to 1 is a little bit slower than that. So here, rate control, what heart rate parameters. I think the most important thing for you to know is that we just try to keep heart rates, for resting heart rates, we like them less than 100. But, dynamically, if they're up and moving about, less than 110 is fine too. So we don't get too crazy. You're not trying to keep them less than 60 beats per minute. Really, they need, because the heart's being inefficient and not pumping well, you kind of need a little bit of a heart rate for folks with AFib. You just don't want it to be resting above 100 or dynamically if they're walking around above 110, unless they're actually exercising. And then, it's really symptomatically driven. And I won't belabor this part. We kind of talked about it. Don't use calcium channel blockers in heart failure. Otherwise, you can use beta blockers and calcium channel blockers, just not in heart failure. AV nodal ablation. So, this is not as common anymore. And I would say I've had 3 or 4 patients that I've referred for AV nodal ablation as management or of AFib. These are folks that antiarrhythmics have not helped. Maybe they've had 1 or 2 atrial fibrillations. It's not helped. And now it's just time to put a pacemaker in and then just get rid of that AV node. So it doesn't communicate from top to bottom anymore. Now the pacemaker is they're pacemaker dependent, but it also drives their heart rate for them. This is kind of Tachy-Brady syndrome. If you remember The Incredibles, not too slow, not too fast. You have to kind of keep it in a reasonable heart rate range where they're not bradycardic and symptomatic, or they're not rapid ventricular rate and symptomatic. So this is where they were telling their son, faster, faster, faster. No, slow down, slow down, slow down. So anyways, and then rhythm control here in the paroxysmal persistent, long-standing persistent. I actually have a lot of slides here, so I won't read through these, but really there's a lot of 2A recommendations in the rhythm control standpoint. These are all very reasonable. Really, we have to think about if we're keeping people in rhythm control, why are we doing that? Like normal sinus, why are we doing that? Really, it's to reduce its impact on other comorbid diseases like heart failure, diabetes, coronary disease, etc. Okay, and I won't belabor this. This was kind of talking about heart failure, HFrEF, amiodarone or dronedarone are really your therapies. If it's uncomplicated atrial fibrillation, then flecainide or propafenone can be used. Uncomplicated atrial fibrillation. And if you failed flecainide, then you can use the dofetilide, amiodarone, or sotalol. And I know most of you probably haven't prescribed it or haven't felt comfortable doing that. In general cardiology, at least as I've practiced it, I've used all these therapies, and they're great. They're great therapies. Amiodarone is the single most effective antiarrhythmic out there, but everyone gets scared about its side effects. So please, please, please do not use flecainide and propafenone in patients who have had a heart attack and have ongoing ischemia. This is what the CAST trial was all about in 2002, where we found out that flecainide was killing patients after a coronary event, where we thought, oh, they have these AFib events after coronary disease, and so we will use flecainide, and it was killing people. Okay. Cardioversion. Well, let me kind of I'm gonna stop there because I'm getting right over time, aren't I? So let's see if I can get us back to here, and let me go to my last kind of slides. I'm sorry, I really wanted to get into ablation and everything like that, and the different rate and rhythm control strategies. But I think the main thing here is with her, she has stage 3 AF. It's paroxysmal is what we decided because it actually terminated on its own. Here, I gave her rivaroxaban instead of apixaban because it's once daily, and that's what her preference was. And then I gave her metoprolol tartrate, which is a short acting. I didn't want her to be impacted for too long, and it's 50 milligrams. She can take 1/2 to 1 tab. Notice it's PRN. It was not chronic. It's just on hand. I want her to kind of a pill in the pocket strategy when her heart rates are greater than 110 if she's up and active. So rhythm control strategy was reasonable as we did I ordered a TTE and everything else looks like it's fine. But the question is, should I send her to ablation? And I would say in the current day and age, yes. It's a 1A recommendation to consider sending her to catheter ablation for this paroxysmal AFib. So, but in the meanwhile, she elects flecainide 50 milligrams, POBID, She does not have symptomatic coronary disease. She doesn't have LV dysfunction. And she wants to manage it with her own kind of Apple Watch. So anyways, these are the potential instructions for recurrence. If heart rate's greater than 110, use a half tab of metoprolol. You can use an extra tab of flecainide. This is called chemical cardioversion. If she's doing it 50 BID, she can take up to 300 maximum daily. Usually an extra tab does the trick. But I will be texting back and forth with patients to chemically cardiovert them. And then she's then given contact numbers at the clinic, or if there's certain RNs or MAs that are supporting me. And then I'm fine with direct cell contact calls and texts, etc. But she is one that I would say I would have a strong discussion with sending her over to like Brian Crandall, Jared Miller, etc. for upfront AFib ablation. Then here's the summary. So again, identify, reduce elevated stroke risk with anticoagulation. That's kind of key for all of this, regardless of what stage and what management rate and rhythm. Calculate the stroke risk and then use anticoagulation. You can use patient-owned devices. That's helpful to help them understand their symptoms versus when they're in AFib or not. Sometimes they just have symptoms and it's normal sinus rhythm. And then a rate or rhythm control strategy can leverage that device. I know I skipped through a whole range of slides on patient devices, but I think here it's just important to recognize that modifiable risk factors should be modified and optimized, and then protect that brain. I like your rhythm control strategy up front.